My name is Vicki Hetson. Today we're going to take a look at a LEMS case study and get a detailed viewpoint from two thoracic nurse practitioners. This case study was previously presented within our larger educational program entitled The Thoracic Oncology Nurse Practitioner's Role in Patients Living with Small Cell Lung Cancer and Lambert-Eaton Myasthenic Syndrome. This program is sponsored by Catalyst Pharmaceuticals. Please see the Catalyst Pharmaceuticals disclosure statement for both faculty today.
Thank you, Vicki. I'm glad to be here today. These are my disclosures.
These are my disclosures.
So this is our patient. She's a female, age 66, with a 40-year history of osteoarthritis, and she's also having significant anemia. She's a current tobacco smoker. She smokes a pack and a half a day for over 50 years. Her other comorbidities include hypertension, hyperlipidemia, and COPD. Her initial complaint is that she has significantly worsening fatigue, a dry, non-productive cough, and worsening lower back pain that's different from her typical arthritis discomfort. So at the urging of her family, the patient goes to the emergency department.
Upon ED cancer screening and testing, a chest x-ray was done where a large mediastinum opacity was seen. Chest CT, 4.5 centimeter subcranial lymph node with enlarged right hilar mass, measuring 2.6 centimeters and bone metastasis in L3. An oncology consult was requested. A bronchoscopy revealed small cell lung cancer. A brain MRI was done with no evidence of intracranial malignancy. Pathology did confirm small cell lung cancer with a typical IHC profile.
Based on the information so far, what might you suspect in this patient?
Well, I think this is a very typical workup of a patient with small cell lung cancer, very large mediastinal mass, and that's a big lymph node there. It's really typical of what we see. I think the one thing that would concern me in this patient is that sort of severe fatigue that she's having. It looks like she has a bone met at L3, and we would want to probably get an MRI of that and make sure there's no, spinal cord compression there. But likely there probably isn't, and so in that case, she has not been treated yet. Now she does have some anemia, but usually we're not going to see such severe fatigue, and I'd want to know more about why she's having such fatigue and do the workup for that. So for this patient, continuing on with our case study, we would treat her with etoposide, carboplatin, and immunotherapy. That would be our typical first-line treatment. Her cough and shortness of breath improved dramatically, and that's typical. This is a very chemosensitive disease, small cell lung cancer. But her general weakness initially that was attributed to the anemia due to the chemotherapy, she does end up getting a red blood cell transfusion, but that resulted in really no improvement in her weakness, and I think that would really concern me right there.
How common are similar symptoms to patients you see in your practice, Elizabeth?
That's a great question, Vicki. We see these patients with these symptoms on a daily basis. Patients receiving treatment for small cell lung cancer typically will present with these symptoms.
If you were to diagnose a patient with LEMS, how would you implement a multidisciplinary care plan for this patient, Beth?
Well, certainly the first thing is to consult neurology and get them under the management of a neurologist who really understands this disease better than we do and is treating the patient appropriately. But I also think for this patient, they're now dealing with significant weakness in their legs and their arms. So we have to, get an understanding of how is this impacting their daily life. Do they need a visiting nurse? Do they need physical therapy? They probably are going to need an assistive device like a walker or a wheelchair. So we have to make sure that we're sort of looking at all aspects of this.
So additional testing and screening was done. We repeated the brain MRI to evaluate for brain mets, however it was negative. We did a lumbar puncture to test for leptomeningeal disease, which was also negative. We considered potential neurological PNS, and an anti-VGCC, PQ, and N-type tests were ordered. VGCC antibody testing was positive. A neurology consult was made where they found profound weakness in proximal legs and the arms. The patient and the family reported a significant decline in her gait and ability to perform her usual activities. Neurologist performed an electromyography test that did confirm LEMS.
how are we going to manage these symptoms and treat this disease? So the clinical improvement can be seen just from the LEMS in response to the cancer treatment. However, we don't always want to just bank on the fact that the cancer is getting better just from the chemotherapy alone. So really symptomatic treatment is recommended in addition to the anti-cancer therapy. So immunomodulatory therapy can provide a short-term benefit in the management of LEMS, and it's recommended for flares or when symptomatic treatment really is insufficient. So symptomatic therapies that increase availability of acetylcholine, such as amifampridine, or inhibit the degradation of acetylcholine, such as pyridostigmine, are also treatment options and may provide improvements in muscle strength. So in conclusion, with our case study, the continued symptom management for LEMS, the patient has tolerated it well and has remained with limited symptoms. The patient's quality of life has increased significantly and she is able to perform her ADLs. So how would I manage my LEMS patients? Well, first, assess the small cell lung cancer patients for potential weakness, difficulty standing, or irregular gait. And by that, we would actually have to make our patients stand up and walk. And that's an important thing. Sometimes our patients are actually wheeled back into the room, and if we don't actually get them up and walk with them, we're not going to know. So that's one important thing that I'm going to take away from this. Consider that the LEMS in any patients with weakness that's disproportionate to their disease. So for example, in our case study, this patient had an L3 met, but really on the scans, we did the MRI, we did the lumbar puncture, and it was not showing that there was any significant leptomeningeal disease. So that was really disproportionate to what she was reporting to us. If LEMS is suspected, definitely order that paraneoplastic panel or the VGCC testing, and then engage a neurologist to help you confirm that LEMS diagnosis. Once the LEMS is confirmed, then use what we have for LEMS management, such as amifampridine, or immune modulating therapy, such as IVIG, plasma exchange, prednisone, and other treatments that may be available if the patient is only having limited benefit from the amifampridine. So our take-home messages are that we need to promptly identify LEMS and appropriate screening for small cell lung cancer, and that can help improve the outcomes of both the lung cancer and the LEMS. We need to make sure that patients with small cell lung cancer and a paraneoplastic neurologic syndrome, including LEMS, have improved survival, so we need to make sure that we are identifying it early and knowing what to look for. The brain metastases and the leptomeningeal disease can present with similar symptoms, so it's important that we know the differences, and then that we recognize and treat the LEMS, which can also then help their quality of life.
What are two of the most important things you would tell your peer thoracic APPs at UPenn and Texas Oncology to remember about LEMS in small cell lung cancer?
Great question, Vicki. I think I would tell my staff to ensure that they're doing a thorough review of systems, to make sure that if a patient comes in complaining of musculature weakness, that we watch them ambulate, we watch them get up from the seated position, and that we educate across the board. The second thing I would tell them is to get a quick neurological consult, because these patients often go undiagnosed. How about you, Beth?
Yeah, I would agree. Just making sure that we're doing a better neurologic exam and making them walk, because I think we have to start thinking about lower extremity weakness. Is it proportionate to their disease? And if it's not, then we should be working this up. And then I think the other thing to know is that there's actually a treatment available for it. So I remember back, over 10 years ago when I had my patient with LEMS, we really didn't have treatments for this. We were just kind of piecemealing together what we thought we could use. And now there are better treatment strategies for LEMS. So there's something that we can do for them.
And that is good news all around. As nurse practitioners, you are on the front lines of diagnosis and care, and this case study underscores just how vital your role is in identifying conditions like Lambert-Eaton myasthenic syndrome. Thank you again for your attention and your commitment to advancing patient care.